This is Andy Orm at O'Reilly Media, and I'm talking today with Elisa Weitzman, who is a assistant professor at the Harvard Medical School and has worked on an interesting app that works with social networking to try to get people more involved with their care. So Elisa, tell us what your general goals are at the Harvard Medical School and why they are interested in what you're doing.
Well, my general goals at Harvard Medical School, and also I'll mention at the Boston Children's Hospital, are to figure out successful approaches to engaging populations, public health cohorts, in research to advance knowledge, to improve healthcare, health status and outcomes, and in parallel to engage cohorts of patients, and often children and adolescent patients, because I'm in a pediatric setting, in doing the same. So, yeah.
Have you found that the younger people are more interested in using social networks like the one that you were working with?
I think that all groups who are dealing with a problem, all age groups, all communities, have an intense interest. And in fact, the leading group I think that's growing in engagement with online social networks are older individuals and the baby boomer population and older, who often experience a lot of chronic illness.
Yeah, so those are the ones who realize that they better get their life in order.
Right.
But you were working with a group called 2Diabetes in particular. Can you describe that a bit?
Yeah. Well, 2Diabetes is an online community for people affected by diabetes. So most of the members of that community, it's a virtual community, themselves have diabetes, and a small percentage are parents, partners, family members, friends of individuals with diabetes. It's an international community. They're actually, it's a nonprofit, and there are two sibling communities. So there's an English language community called 2Diabetes, and there's a Spanish language sibling site called S2Diabetes, and they are both run by the Diabetes Hands Foundation.
But you are particularly interested in getting information that's usually not, that patients usually don't give up, and you found a way to do that.
Yeah, well, in a variety of, for a variety of reasons, I stumbled across the fact that the individuals who may have the most information, most useful, relevant information that we might harness for public health research, for care improvement, for population-based research, are finding each other online in virtual communities. And one of those communities, it happens that diabetes is a very active space in terms of online disease-centered social networks, and 2Diabetes is a very engaging, high-quality site. So anybody who's tried to do population-based research knows that it's costly, laborious, often very frustrating to pull out from cohorts the kind of information that is really helpful to advancing what we know and wrapping back to helping the individuals who are research participants. So our goal and our observation was really that there is a gold mine that already exists, which is, if you look over here, there are these vast populations of individuals talking to each other online about the very things that we want to know as researchers about symptoms, outcomes, treatments, side effects, quality of life, comorbidities, cofactors. All that exchange is happening organically. What would be helpful for anybody would be to tap into that exchange in a structured way and pull information out.
It seems also you felt that the patients themselves could benefit by seeing what other people are going through and what their glucose levels and so forth.
Absolutely. Well, the reason that individuals are in these communities is that they want to be talking to each other. So now when individuals talk to each other, they often do it in a very unstructured peer-to-peer fashion. We thought we would layer some value onto that by creating a software application that would collect structured information using validated, sort of standardized approaches, and then be able to feed that information back selectively to individuals who wanted to see something about themselves in the context of other people, but also we created opportunities to feed back population data to the entire community as a means of continuing to engage the community in the research, but also to benefit from their contribution or donation of data. And there, from a public health and a research perspective, I often describe the research enterprise, if you're a patient participant as a one-way suck, that you are giving a lot of information and you rarely, if ever, get anything back. You hope to benefit the enterprise, you hope somebody else, and maybe yourself down the road will learn something from it. But this project was about a closed-loop approach where you could contribute data and you could receive information back in a kind of a virtuous cycle.
So the Children's Hospital engineers created 2Analyze.
Correct.
And tell me a little bit about the app, what you take in and what you show back to the patient.
Right. Well, 2Analyze, which is sort of branded, if you will, within the concept of 2Diabetes, is a software application that has a number of features. First, I should note that it's not a standard software application. It has when individuals use it, they're authorizing creation of a personal health record or a person-controlled health record using the Indivo software on the back end, so that any information that an individual would enter into the application in the context of their participation in research and in online social networking through 2Diabetes would be fully under the control of that individual. So research data reported by you or I, if we were participating in that, would not exist on the network where it might be scraped by individuals we didn't give access to. So the data flow into a personal health record, and that allows us to, as investigators, to pull across consented records. So that's a key feature of the software, would be the person-controlled health record component. In addition, there are several kind of interactive features of the software. One is, the user interface has a presentation of the terms and conditions for participating in research, which would be fairly unique. So you agree and opt in to being a study subject. It's something like an informed consent by agreeing to participate. There's transparency around how your information is used. And actually, there's some fun features that let you, for example, enter the values of your hemoglobin A1C, which would be a biomarker for how well you're controlling your diabetes, and have that information in a permissioned way be used to populate real-time surveillance maps, GIS maps, that show you patterns of glycemic control for other individuals in the community using that feature. So that's one highly engaging feature of the application that we launched with. And another would be a survey tool, which allows individuals to report about their diabetes, their health status, their comorbidities, their psychosocial status in a highly structured fashion, and again allow that information to be used for research purposes.
When you talk about a community, you told me before that the patients can see what's going on in their state.
Yes.
Or their province if they're in Canada.
In some instances they can. So for in the GIS mapping feature for the A1C data, the hemoglobin A1C data, if I entered a hemoglobin A1C, that information would go into, for the United States, a state level kind of aggregator. And I could, if I were not a user of the system, I could request to see a frequency distribution of the users' A1Cs in the community, de-identified and aggregated. So I would see how many people had A1Cs that were above me or below me, and I could click through some tabs and say, well, I want to see that as a bar chart, or I want to see it as sort of a series of bullets, which give me feedback on what percentage of people have what levels of A1C. And then if I entered my own data, I could see a value that said me, overlaid on that. So I could do something that's very important for people who are trying to manage a disease over the entire course of their life, which is to be able to get some feedback on how am I doing, and how am I doing relative to people around me as a motivator, as a reference point. So that feature is live in the U.S. at the state level. You can pull back and look at it at the country level. It's color-coded using kind of a standard fun stoplight kind of system. So if you're really high, it's red. If you're sort of around where you should be but high, it's yellow. And if you're doing really well, it's green. Same thing the American Diabetes Association uses, so you can see very quickly where these communities are in terms of their level of blood glucose control. And that feature then is available at the province level in Canada or country level outside the U.S.
And then back just a couple of days ago on February 11th, you published a new paper which is about when people have hypoglycemic episodes, which is a very serious, dangerous situation for them. Yes.
Correct. Well, so one of the things we've been interested in is tracking measures that reflect both quality of life, daily experience with the disease, and problems with medications or complications. So as you mentioned in the hypoglycemia paper, we were interested in tracking what are the, if you will, the side effects or adverse events related to insulin use, which is commonly prescribed for people with diabetes. And there we were interested in reporting not only about severe hypoglycemia, so what is the frequency with which individuals really get in trouble and their blood glucose level drops to the point where they need assistance from somebody else, or they have a seizure, or they become unconscious, but also what about the daily experiences of going low, which for many people with diabetes can be overwhelming and sufficiently anxiety producing that they start to their world starts to retract. They stop doing the things that they would normally do in life out of fear that they're going to have a low, their blood sugar is going to drop, and they're going to be endangered themselves, or they will endanger somebody else. So we wanted to really characterize that, to test the model of whether we could collect safety information, but also so we could really address known gaps in terms of side effects of insulin.
So you've got a lot more information than researchers normally have been able to obtain, it seems.
Yeah, and stepping back, looking at the big picture, I think that's one of the benefits of engaging with a community like 2 Diabetes or any other of the communities out there that are in this sort of unique milieu, which is that we tend to rely on 2 data sources for most of what we know about health and healthcare. One would be constructed population-based research data sets that are often still contacted by telephone. So you reach a certain segment of the population and you know something about their health. These would be standard public health surveillance mechanisms that the CDC would run, for example. And those have terrific breadth but very little depth. They also have limitations of selection bias because only certain people answer the phone or come to the door or agree to participate in research. So we know something, and it tends to be shallow but broad about health from those surveillance mechanisms. We also tend to track outcomes and problems by looking at things like emergency room admission rates. So we tag problems with people coming into the ER. And we know something about hypoglycemia by tracking ER admissions. When people come in who have a really serious problem, are brought in by ambulance or something, we can track that and say, well, what do we know about this problem? But those 2 data sources miss a huge amount of the experience of something like hypoglycemia, and in fact, they miss a huge percent of the individuals who are on insulin. And I think it has been well recognized that we have holes that we really lack viewpoints or windows into the experience of patients around safety, whether it's with devices or medications or all kinds of therapeutics, and we need to figure out how to engage in a conversation with the vast majority of individuals and say, what's that like? What problems are you experiencing? And learn about them. In the case of To Analyze, we also have the opportunity, because we've preserved a communication channel with the study cohort, of feeding that information back and following up, which tends to be something that's precluded by the way we do research
Feeding
in these
them
other.
Back to the patient or to the clinician?
Potentially. We're not talking about a clinical connection at this point. This is sort of set up as a public health effort. But anybody who opts into using To Analyze, you have an access point to contacting that person. In fact, that was one of our earliest tests that we reported about with the To Analyze application, was to see how we set up all the defaults of the system in a very conservative way that would allow individuals, the defaults would be highly restrictive of the sharing of information and recontacting. And we wanted to know, would individuals consciously, deliberately opt into and pull back on those restrictions so that they would show us clearly the extent to which they were willing to participate in research and how willing they were to be recontacted on a follow-up basis. And virtually all study subjects, something like 97%, changed the default setting from don't contact me to contact me about ongoing research, which was a really marvelous picture of engagement. And then we saw clearly how individuals wanted their information to be shared. So that was very helpful.
How big was the population that engaged with the to analyze or over the other?
I think in all told we have maybe 3,600 participants right now who are using the application, and they hail from about 60 countries and all 50 U.S. states.
Great.
Yeah.
Let's step back a minute. Because you're doing public health,
yeah.
What are some of the ways you can use the data, or other researchers can use the data to improve how we treat diabetes?
Yeah. Well, I think a good example here would be understanding hypoglycemia, because you see, how concerning it is to individuals, how frequent it is, the kinds of daily experiences and problems people encounter. So I think for clinicians to recognize that they really need to track hypoglycemia, ask about it, that's extremely important. And all the other measures, we have similar information about in terms of comorbidities that individuals, it's not a new result that individuals with diabetes would have other health problems, but we can see very clearly who does and what is the extent of that problem. And so that's, I think, very, very helpful and useful information. The piece we're not talking about would be the clinical piece, which is, you could look at that in two ways. How might clinicians and healthcare organizations join this party, if you will? And then the converse, what are patients taking back to their clinicians and either asking for or sharing or kind of bringing into the conversation that might be shaped and influenced by what they're learning from their peers and from the data we're feeding back. And so those are two pathways by which we might start to include healthcare and clinicians in this conversation.
That would be another level of research.
Yeah.
That would be worth doing.
Yes.
Yes. Is there anything else that you would like to say about the work of the group? Well, I kind of want to offer that the work of the group is really just beginning, that learning how to engage populations as active participants and conscious participants in not just their own health, but the health research that ultimately drives advances in the evidence base to benefit them. That's really vital. None of us have enough money, time, or resources to figure out how to keep that engine going without the active engagement of populations. So I think, it feels to me like we're on the cusp of something very important, both our group and the field in general, which is to start answering questions about how do we create this thing called citizen science or, citizen public health or citizen health research, so that all the various people who might benefit from and have something to contribute, whose voice really needs to be heard, for us to understand and change healthcare or advance public health. How do we create mechanisms to talk to them and keep talking to them, since problems like this are problems individuals carry over a lifetime, and your experience today is not your experience tomorrow. So to really understand a problem like diabetes or obesity or any of the other issues, I'm working on, like pediatric rheumatologic disease or asthma in pediatric populations, that's an unfolding story over the course of a life. And I think NIH and others have grappled for a long time with how do you get these vast populations with enough information to really explain something, to hang in there with you as a collaborator in research. And I think we're just starting to figure that out. So I don't know if that puts the edge on our agenda, but... I wanted you in here because patient engagement is the buzzword of the era, meaningful use and a lot of big institutions.
Right.
But saying we need it and doing it are different things, and I think you're on the way to find ways.
I cross my fingers. I think, we're trying to be on the way. I would say, here's the thing. Patients are really engaged. If you go do a search and find some of these big online communities, millions of people are out there seriously engaged with each other, trying to find and learn from each other what works for what problem, and even to refine the understanding of the problem they have. They're heavily, heavily engaged. They're just in an orthogonal space to everybody else. The clinicians are here, and the researchers are here. And, the question is, what are the bridges to, how do you build the bridges to harness that engagement? I think that's where we really need to think long and hard. I think most people very readily tell you they benefit from even sharing their story, right? So patients feel that benefit all the time. It's just who's listening, and are you listening with ears that can really pull out of that story something that is relevant and rigorous. That's the trick here. I think it's not that patients aren't engaged, but they're just engaged separately.
And the researchers know better than most patients what data they need, how to structure that data so that it's useful for research purposes. And an app may be able to make the bridge between the patient and the researcher.
I think so, and also solve, maybe not solve the problems, but, start framing some solutions which, change the model or the paradigm a little bit. At this model of the one-way suck I described earlier, that, study subjects historically always feel like they're donating, but nothing comes back. So, if you can have if you can activate a model where it's almost enlightened self-interest. I don't mean to be crass, that you're sort of cynical in offering that model, but why can't it be a yes? Why can't the patient benefit? Why can't the cohort benefit and the investigator benefit and care improve? But are we really living in a world where we're all so siloed that our interests don't align? And so I think that's really the enabling role of technology, which is to help to create a platform by which these interests can align. And that's really our job, and that's the sort of pioneering piece of what we're trying to do. And I would credit the Children's Hospital Informatics Program and Harvard Medical School Bioinformatics for really recognizing, I think my colleagues well understand that that's the task at hand. If they don't align, I feel strongly that the opportunity will be foreclosed, because even my own research, other papers demonstrate that there are conditions that individuals bring to the table. They much prefer to be in nonprofit research. They much prefer to learn about the results of their findings. They don't want to just be part of something where it's all commodified. They're much more likely to tell you about something if they recognize that you're in a kind of a pro-social organization, for example. So, I think those are all pieces of the puzzle about what are the triggers for engagement, but, it also has to be interesting and hopefully fun and meaningful.
I want to ask you about another stage we can take this to.
Yeah.
You say patients would rather have a nonprofit research organization. So you're lucky, you're well-funded, but you still have a very limited sort of base on which you can work. So how could this be something big and still be nonprofit? Is it going to be government? Is it going to be more institutions supporting it?
That's a darn good question. The truth is, business is heavily engaged in this area. They're engaged in app development. They're building all kinds of, tools. There's a serious business model at work in terms of mining data off of online health-related communities, because it's really relevant data to a lot of advertisers. So, there is a business presence there. My own research really shows that patients, and it's not just in the virtual world, but, patients in general have a preference to make a contribution, and the contribution is sharing their own personal health information where they feel that it is pro-social. Now, that doesn't preclude a partnership between public and private sectors. But I think the terms of that partnership to support something financially would have to involve transparency. You know, I mean, individuals should know, and I think want to know, what data are being shared with whom for what purpose. And I'll just throw out there the fact that it's in all of our best interests as investigators and probably commercial, entities to ensure the conditions of that transparency, because individuals will opt out and leave communities or environments that they feel are predatory or inappropriately using their information. So the task for us is to figure out how do you keep populations engaged? How do you avoid turning them off and introducing these kinds of inhibiting factors for engagement? And if individuals feel that they really are in some way being manipulated, then I think none of us are going to succeed. And I say that in part because we shouldn't kid ourselves, that problems we want to solve are formidable. Diabetes, massive and expensive, right? To really figure that one out, all hands need to be on deck, but also you need these vast populations engaged. So you need those numbers. Obesity, similar thing, right? I mean,
asthma in the inner city is very hard to treat.
Very hard to treat, and asthma in pediatric populations ends up being very hard to treat in general. And so understanding any of these things, I mean, goodness, you could open the door to cancer and heart disease and all of them. If they were simple problems, we would understand them. The fact that they're so complex and such moving targets means we're only going to understand them when we have in place studies with enough individuals participating that we have the variability required to understand the problem. And in asthma, whether it's the biology, the physiology, the environmental triggers, the stress pathways, when you start to build that model out in terms of the causal model of the disease, you recognize right away its enormous heterogeneity, and the fact that 100 people here, 100 people there as your study subjects is not going to do the trick. Right? You need vast populations.
Thousands.
And when you're talking about testing preventive interventions or the impact of policy on outcome, which are other levers we have available to us, right? Beyond just therapeutics and medications, you need similarly scaled populations. So if all of us need large populations to participate, then we better figure out how to protect the interests and rights of those populations so that they engage and stay connected. Because these are health problems that unfold over a lifetime.
And the nice thing about using an app and using an open source database like Indivo is that it scales very cheaply. So at least at that level, we can hopefully get a lot of people involved without needing a lot of money.
Yes. Well, I mean, I think you can certainly build on the investments that were made in the core technology without a doubt. And there's no question that, apps that operate on data platforms, for example, are likely to be a highly cost-effective way to go. Yes, agree.
Well, thank you for coming in.
You're welcome.